Okay, I'm starting the recording. This meeting is being recorded. It will eventually be hosted on the OHA's website. And I wanted to welcome everybody to the second meeting of 2026, our April P&T meeting. We do have a quorum of committee members. Appreciate my team calling out or helping nudge me if there's somebody I've missed so that I can make them a co-host so they're able to mute and unmute their lines. But with that, I wanted to get started. For those members of the audience, if possible, if you can, please edit your name to add your affiliation. So for example, if you're working for industry or you work for one of our coordinated care organizations, if you can append that to your name, it would be helpful for us to capture that in the minutes. And if you are where you found the link for this meeting, there also is the meeting packet of materials posted. We'll be following along. I'll try to call out the page numbers as we have different sections. So we're going to be starting up at the top of the order with roll call and introductions. We've got the P&T committee members listed on this page. Bridget will be joining us, but she had a conflicting meeting, so she might be about 20 minutes late. So Tim, we'll move on to you for introductions. Can't hear you if you're talking. You might be on mute. Did we lose Tim? Tim, are you able to unmute your line? Well, Samara is also going to be joining us in just a minute. Doug, let's move on to you. Are you able to unmute your line?
I am. I'm Doug Carr. I'm a board certified internist and medical director at Umpqua Health.
Appreciate it. Thanks, Doug. Russ, we'll turn over to you.
I'm Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Eriko, are you able to unmute your line?
Yes. Hi, I'm Eriko Nishi, OHSU Family Medicine.
Welcome. Tim, I'm going to go back to the top of the order. Are you able to unmute? Welcome.
Yes, I'm sorry, I had to step out for one moment. I'm Tim Langford. I'm the pharmacy director with the Klamath Tribal Health Facility.
Thank you, Tim. Eddie isn't able to join us, so Pat, we'll turn it over to you.
Hey everybody, Pat DiMartino, pediatrician and transplant doc at OHSU.
Welcome, Pat. Jennifer.
Howdy, Jennifer Henderson, sleep medicine doc and regional medical director with Asante in Southern Oregon.
Welcome. Thank you, Jennifer. I don't think Stacy's going to be with us today, and you'll see a new name at the bottom of the order. So we have Dr. Bruce, who will be joining us at our June P&T meeting. Jeannie Savage had to step away from the committee. She's going to be doing some important work with the HERC on one of their subcommittees. And thankfully, we had a pediatric psychiatrist that was interested in waving at windmills with us. So he was appointed by the OHA to join the committee. Excited to introduce him to everybody in June. And with that, we'll move on to staff introductions. I didn't see Jennifer joining us, so I'm Roger Citron. I'm the director of the Drug Use Research and Management team, and we help provide the clinical support to the OHA. I also did not see Trevor, so Dave, take it away.
Hi, I'm Dave Engen, clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the P&T clinical coordinators for the OSU Derm team.
I'm Andrew Gibler. I'm the clinical pharmacy policy and programs manager with OHA.
We skip down to me. I'm Deanna Moretz. I'm one of the pharmacists with the Derm team.
Thank you, Deanna.
I am Kathy Centena, and I'm a clinical pharmacist with the OSU Derm team as well.
And hi, my name is Sarah Servid. I am one of the PNT clinical coordinators with the Derm Group.
I'm Lance Starkweather, Pharmacy Manager for Gainwell Technologies.
I'm Dee Weston. I'm Pharmacy Program Policy Advisor with OHA.
I'm Brandon Wells, the Pharmacy Program Policy and Operations Analyst for the Fee-for-Service Program at OHA.
And neither Ted or Michael are joining as well. So if you're following along on the agenda, we've just gone through introductions. We have the approval of the agenda and minutes. Oh, excuse me, conflict of interest declaration, vitally important to the OHA. All of the OHA staff, all of my team, so the supporting team, DERM, and all the P&T committee members have conflict of interest declarations on file with the OHA. There is an expectation that should a conflict arise for one of the topics we'll be discussing in P&T, that a committee member would recuse themselves. We also provide an opportunity here at the top of the order for anybody to disclose or bring any conflicts to the attention of the OHA. And so I'll pause for a moment to see if there's any conflicts or if anybody needs to recuse from a subject. Hearing none as expected. We also, anybody that'll be providing public comment today has submitted a conflict of interest declaration, including those that have submitted written testimony, which is posted to our website and brought to the committee's attention. So yeah, just wanted everybody to know that. And next we'll go on for the approval of the agenda and the minutes. So the minutes from the last meeting were sent out to the committee for review. We'll see if there's any edits that are recommended, and if not, we'll entertain a motion to approve them.
Move to approve the minutes.
Thank you, Doug.
Second.
Is there a second? All right. Thank you, Russ and Tim. All in favor, say aye.
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 Anyone opposed? Any abstentions? All right, minutes are approved. Next, we'll turn it over to Andrew for the department update.
Thank you, Roger. No updates from our department. We're just plugging along, but do want to express our gratitude for your time here and efforts in this meeting. The Mental Health Clinical Advisory Group has a few openings. Just to get the word out, I would like to share those with you. As you know, the Mental Health Clinical Advisory Group by Oregon law advises the P&T Committee on Mental Health Treatments and is composed of several mental health specialists, psychiatrists, as well as primary care physicians, pharmacists, CCO representation, psychiatric nurse practitioner, consumers, and advocates. We do have one actively practicing psychiatrist seat open and one open seat for a psychiatric nurse practitioner. We are looking for CCO representation as well, and we're looking for an advocate that represents a Oregon statewide mental health advocacy organization. MCAG recently published, they've been working on, among other things, assessment and treatment of ADHD in adults, and they approved and published guidance on assessment of ADHD in adults, and that publication is available on the website. If you just type in OHA Mental Health Clinical Advisory Group, it comes right up. You'll see our recommendations on the right there. And you click into that and you'll see all sorts of tools and resources for not just providers, but also patients. And the new one is assessment of ADHD in adult patients presenting with ADHD symptoms. So I'd encourage all of you to please look at that and share it widely. And that's all I have, Roger.
Appreciate it, Andrew. Who is providing a legislative update? I don't know if there's much to present, but.
I don't have anything to present.
I was scrambling off mute. I don't think Mary Beth can join. If you give me 1 minute, I can share the blurb that she prepared for me to present to the CCO pharmacy directors. I just need 1 moment to pull it up. Is that okay? I guess.
Yeah, absolutely. Go ahead. If you want to pull
Okay,
that up,
okay.
I'm going to interrupt
Yes,
for
I've
one
got it.
second. We had Dr. Stevens, Samara Stevens was able to join us. I made you a co-host. Are you able to unmute your line, Samara?
Sure am. Thank you.
Yeah, thanks for joining. We just got started. We have a quorum, so we got through the approval of the minutes. And Dee is just digging for some information for legislative updates. So just wanted to orient you. But if you want to briefly, give an introduction.
Yes, thank you. Hi, I am Samara Stevens. I'm a naturopathic physician in private practice up in Portland.
Welcome.
Thanks.
Okay, and I'll just read this blurb that was prepared for us by our legislative coordinator. On Friday, March 6th, the legislature adjourned, bringing the 2026 short session to a close. Despite being a 5-week sprint, the legislature weighed many important policy bills and rebalanced the state budget. Few bills this session directly impacted the world of pharmacy, but we anticipate a more robust conversation on pharmacy in next year's long session. One bill that passed related to pharmacy was House Bill 4131, which directed the State Board of Pharmacy to issue licenses to operate mobile pharmacies to specific partners throughout the state. Another bill that did not pass, but will continue to be a conversation this year, was House Bill 4003. This would have made changes to Oregon's prioritized list of services. Even though the bill did not pass, the Oregon Health Authority submitted a letter to the legislature committing to the actions outlined in the -3 amendment of the bill. As the state Medicaid agency, OHA will continue to ensure Oregon is in compliance with our federal partners. Let's see, I think that was it. Oh, for more detailed information on what OHA was tracking, you can review the Government Relations Team 2026 end of session legislative report, and I will drop that link in chat. Hopefully that will work.
Appreciate that, Dee. Just once again wanted to encourage anybody that's attending in the audience, if you can add your affiliation, be it industry name or CCO to your name, be appreciated for us to capture that when we record that with the minutes. So next, if you're following along in the packet of materials, draw your attention to page 8. It is our oncology prior authorization updates. It's part of the consent agenda. It's just a way for us not to present the full-blown information and add drugs to our policy. So we would entertain a motion to approve the consent agenda.
Motion to approve.
Thank you, Russ.
Second.
Appreciate it, Doug. Samar, we're engaging you now.
All those in favor?
Aye.
Aye.
Anyone opposed?
Abstain?
Perfect.
Hmm.
I am going to go off camera just because it's quite distracting for myself, but we'll continue on. So next, we're going to go to the analgesic class update. That starts on page 16 in the packet, and we'll turn it over to Sarah.
Thank you. So today I'm going over a handful of different classes, and the primary purpose of this review is to evaluate new comparative evidence in the analgesic drug space, and then also to evaluate evidence for what are currently unfunded conditions on the prioritized list. As background, pain is overall generally classified into 2 different ways. One based on duration of the pain. Acute is generally classified as pain that lasts less than 1 month. Chronic is classified as pain that lasts more than 3 months. And then you've got subacute in the middle there with pain of 1 to 3 months duration. The literature also classifies pain as primary pain, which is pain that's unrelated to an underlying condition, or secondary pain, which is pain that's caused by a known cause. Guidelines generally recommend for all durations of pain a multimodal approach for pain management, which includes both drugs and non-drug interventions, including physical interventions, psychological interventions, exercise, and education on sleep, nutrition, stress reduction, and knowledge of pain. There are many different classes of pain medications. In chronic pain, a lot of the evidence hasn't demonstrated clinically significant differences in pain or function between classes of analgesics or between individual drugs. Opioids are generally not recommended for chronic pain that lasts longer than 3 months because risks of opioids are generally thought to outweigh the benefits for most patients. And then in acute pain, treatment choice is typically tailored for conditions where there is evidence of benefit. And so treatment of the underlying condition is important. And then you'll see things like NSAIDs for inflammatory conditions, muscle relaxants for low back pain and spasticity, and then combination of products for postoperative pain, including NSAIDs, acetaminophen, gabapentinoids, opioids, or suzetrigine. They all have evidence in postoperative pain. In 2025, the Oregon legislature did pass a Senate bill that impacts this class of medications, Senate Bill 598. And the goal was to ensure there was at least one clinically appropriate non-opioid prescription drug available as an alternative for each opioid prescription drug, and ensure that the utilization controls and prior authorization requirements are no more restrictive for non-opioid prescription drugs than the utilization controls and prior authorization requirements for opioid prescription drugs. So currently in the fee-for-service program, there is no prior authorization requirements for preferred NSAIDs, muscle relaxants, topical pain medications, gabapentin, carbamazepine, acetaminophen, short-acting opioids beyond 7 days or 90 morphine equivalents per day, suzetrigine beyond 2 days, antidepressants, or any pain medications that are actually administered by a provider in a clinic setting. We do require PA for all non-preferred products, and then we have specific criteria for the drugs that are listed here. So that includes all long-acting opioids and pregabalin, ketorolac beyond 5 days, cariprazole, that specific muscle relaxant beyond 2 weeks, lidocaine patches beyond 3 tablets per day. And then, like I mentioned earlier, the short-acting opioids beyond 7 days or 90 morphine equivalents, and suzetrigine beyond 2 days. So currently, because we have multiple non-opioid pain medications that are available without prior authorization or utilization controls, my understanding is that the current fee-for-service policy meets the requirements of this new legislation. And then getting into the evidence, new evidence that was published since we last reviewed these classes for acute pain conditions. There was guidelines from the VA and Department of Defense and NICE for acute low back pain. Both of these organizations recommend NSAIDs for low back pain that lasts less than 4 weeks in duration. There was a new systematic review that Cochrane published for acute gout flares, and they found that non-selective NSAIDs, specifically indomethacin or naproxen, had similar symptom improvement compared to selective COX-2 inhibitors such as celecoxib or glucocorticoids, based on low to moderate certainty evidence. Non-selective NSAIDs were associated with more adverse gastrointestinal events and withdrawals due to adverse events based on moderate certainty evidence. And then a series of Cochrane reviews for post-operative pain found that in people with breast surgery, NSAIDs may reduce pain intensity within 24 hours, reduce need for rescue opioid use, and decrease the risk of nausea and vomiting compared to opioids. And then in acute postoperative pain in children and adolescents, ibuprofen had small improvements in pain intensity within 24 hours following surgery compared to acetaminophen, and fewer adverse events compared to either opioids or ketorolac. They also compared diclofenac to opioids, and diclofenac was associated with less nausea and vomiting, but increased risk of bleeding compared to opioids based on moderate certainty evidence. And then getting into the new evidence for chronic pain, there's overall insufficient evidence to compare efficacy or safety of specific agents within each class of medications for the treatment of chronic pain. Again, guidelines include recommendations mostly based on where there's evidence for particular medications. And then almost all guidelines mention that medication should be offered in conjunction with non-pharmacologic and psychologic therapies for chronic pain. And then as far as specific recommendations for classes of medications, there were several new guidelines published for various types of chronic pain, and the organizations and type of pain that they focused on are listed here, along with recommendations. This slide covers recommendations for antidepressants. So SIGN, the Scottish Intercollegiate Guideline Network, recommended duloxetine for all types of chronic non-cancer pain. Similar recommendations from the VA and Department of Defense for chronic low back pain. They found evidence supporting use of duloxetine in that population. NICE recommended antidepressants, specifically amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine, or sertraline for people with chronic primary pain. So again, that is pain unrelated to an underlying condition. They found evidence supporting that these medications can help improve quality of life, pain, sleep, and psychological distress, even in the absence of a diagnosis of depression. For neuropathic pain and painful diabetic neuropathy, both NICE and the American Academy of Neurology also support the use of antidepressants. For duloxetine or amitriptyline were supported by NICE, and then either SNRIs or TCAs were recommended by the American Academy of Neurology. And then there were a handful of recommendations for other specific types of chronic pain. In trigeminal neuralgia, NICE supported the use of carbamazepine as initial treatment of chronic pain. Gabapentinoids and topical capsaicin cream were also recommended by NICE for painful diabetic neuropathy. For all types of neuropathic pain. The American Academy of Neurology for painful diabetic neuropathy also supported use of gabapentinoids and topical capsaicin. They also had recommendations for sodium channel blocker antiepileptics, which include lacosamide, carbamazepine, oxcarbazepine, lamotrigine, and valproic acid. For the treatment of spasticity and MS pain, NICE recommended baclofen as initial treatment and gabapentin as a second-line treatment if there was insufficient benefit from baclofen. The American Academy of Orthopedic Surgeons supported NSAIDs for knee osteoarthritis, both topical or oral NSAIDs, and the VA and NICE also recommend NSAIDs for chronic low back pain. As far as recommendations for opioids, there was one systematic review from Cochrane that looked at opioids for cancer-related pain and found similar pain relief between controlled release oxycodone and morphine based on low certainty evidence. And multiple guidelines did issue recommendations for opioids in people with chronic pain conditions, and by and large, they recommend against offering opioids for all types of chronic non-cancer pain. Both direct and indirect evidence suggests that individual opioids are similarly ineffective for chronic pain management, and they are associated with long-term risks. So guidelines recommend use of alternative treatment options before considering an opioid, as well as monitoring and risk mitigation strategies if opioids are prescribed. Guidelines generally recommend multimodal and interdisciplinary care, both for treatment of pain and for people who are deprescribing opioids. So those multimodal strategies emphasize non-pharmacological treatment options and then self-management strategies with evidence demonstrating that some of the more intensive interventions are really more successful for pain management as well as tapering off opioids. And there is evidence that in people with severe opioid use disorder, deprescribing alone without access to long-term substance use disorder treatment and care and these supportive measures is associated with increased risk of harms based on moderate certainty evidence. So based on these updated guidelines and systematic reviews, there's no changes recommended to the preferred drug list based on the clinical evidence, and are recommending evaluating cost in executive session. There are some updates to the prior authorization criteria for these classes of medications, and I'll walk briefly through a summary of those changes. So I'm recommending updating the NSAID PA criteria to strengthen language for use of preferred products, so requiring providers to document why a preferred product is not appropriate before they can get a non-preferred product. And similar updates to muscle relaxants and short-acting opioids as well. In addition, in the muscle relaxant PA criteria, we're removing some of the funding questions. Since in 2027, everything is going to be funded on the prioritized list, and instead adding questions to ask about baseline assessment as far as severity of the pain and documentation of symptom improvement for chronic use. Also recommending adding a question about concomitant prescribing in the setting of opioid tapers to allow people to be on both a muscle relaxant and an opioid if they're tapering off the opioid. And then for the short-acting opioids, recommendations to remove specific questions for pain related to the back and spine, and instead replace this question with a question asking about how long the people had been on the opioid. Current evidence shows that chronic pain related to the back and spine is probably not any different than chronic pain in other conditions. Opioids are similarly not recommended. And so instead asking if the patient has been on an opioid for more than 30 days and if the prescriber intends to prescribe more than 30 days, if they have a near-term reevaluation of therapy to document whether the opioid is having any benefit or not. And then for renewal therapy, so this is chronic therapy if the patient's been on an opioid for more than 6 weeks, adding requirements for behavioral health treatment referral, consideration of antidepressant prescribing, and then requiring naloxone prescribing with the opioid. And then also revising the requirement that was currently in our PA criteria that asks the provider to document if it was unsafe to taper, changing that instead to document a recent risk assessment for a taper. Based on what we've seen, providers don't document why they aren't tapering. Instead, they document why they are prescribing opioids. And so this question is intended to better align with what prescribers are actually doing in practice. And then for the long-acting opioid PA criteria, there are lots of changes to reorganize and streamline questions and kind of align the language with the short-acting opioid criteria. So we're also adding reference to antidepressants and behavioral health therapy in the long-acting opioid criteria. And then similarly, asking about risk assessment, whether they've talked with the member about whether a taper is appropriate, and then if it's not appropriate and the patient has risk factors for overdose, requiring referral for OUD management. So I'd be happy to take questions if people have them, or we can walk through the PA criteria changes in more detail.
Questions for Sarah? All right, let's briefly touch on the PA criteria proposed changes, and then we will entertain the public comment.
Okay. And the specific changes are in the packet of materials starting on page 50. And so basically outlines what I've described here. But if there are specific questions about the language that's in there or the order of the questions, yeah, happy to take those after people have reviewed them for a second.
All right, with that, we're going to start our public comment. First up, we have Jessica J. from Vertex Pharmaceuticals. Jessica, are you able to unmute your line?
Yes, I am.
Fantastic. I'm going to bring up timer, and with that, the floor is yours.
Awesome. Hi, everyone. My name is Jessica J. I'm a pharmacist by training with the field HOR team at Vertex Pharmaceuticals. Thank you for the opportunity to provide a public testimony regarding Journavx. In January 2025, the FDA approved Journavx, the first new class of therapy for moderate severe acute pain in more than 20 years. Prior to approval, opioids were the only oral monotherapy indicated for the initial treatment of moderate severe acute pain. As of January 6, 2026, Vertex confirmed durable unrestricted access policies of Journavx, which is defined as no PA, no step therapy, and quantity limits greater than or equal to 14 days in 21 states, representing approximately 38% of total Medicaid lives. As previously shared per the FDA guidelines, we conducted the two largest phase 3 randomized double-blind controlled trials in established hard tissue and soft tissue models of acute pain. When compared to placebo, Journavx demonstrated statistically significant reduction in moderate to severe acute pain and a faster time to clinically meaningful onset within 48 hours, and was generally safe and well tolerated. We would like to respectfully ask to change the Journavx quantity limit from 5 tablets, which is 48 hours, to 14 days for post-operative pain immediately following a surgical procedure and for acute pain for non-surgical patients. Acute pain is sudden in onset and peaks 48 to 72 hours following surgery. We understand that with acute pain, patients are treated on average for 12 days. This helps shape one of our phase 3 clinical trials where we allowed for treatment with Journavx for up to 14 days. In our phase 3 study of single-arm open label use, we evaluated the safety of Journavx in 256 participants with moderate severe acute pain, following a broad range of surgical procedures or non-surgical conditions. Additionally, new evidence from 2 single-arm phase 4 studies further supports the pivotal trial findings. Journavx was examined as part of a multimodal therapy treated up to 14 days across a broad range of aesthetic and reconstructive surgeries that would typically be treated with opioid therapy for at least 72 hours post-operatively, which was study 113, and laparoscopic procedures of the intraperitoneal or retroperitoneal cavities or arthroscopic orthopedic procedures, which is study 108. In recently presented results of study 113, 90.9% of participants were rescue opioid-free through the end of treatment. In study 108, 76.1% were rescue opioid-free. The safety profile of Journavx in both phase 4 studies was generally similar to the phase 3 studies. Newly published real-world claims data analysis of Journavx utilization examining prescribing patterns across payer types within 9 months of FDA approval demonstrate that Journavx is being used in a diverse population from 70 to 100 years old with the median day supply of 15 days. More than 30% of patients receiving Journavx underwent surgery across a broad range of specialties. In conclusion, we would appreciate the opportunity to review the proposed criteria of Journavx and respectfully ask for equitable access for Oregon Medicaid beneficiaries with no PA, no step edit, and for a quantity limit of up to 14 days for anyone who is prescribed Journavx. Thank you for your consideration.
It's like you practiced that. It was right on time.
I definitely did.
Great job. Any questions from the committee for Jessica? Okay, thank you. Next, I have Barbie Engel from the International Pain Foundation asked to provide public comment. Are you able to unmute your line?
I think I did.
Fantastic. You hear loud and clear. Since you're not with industry, you were actually requested by Vertex to be attending. So with that, the floor is yours.
Thank you. Good afternoon, members of the Oregon Pharmacy and Therapeutics Committee. My name is Barbie Engel. I'm Vice President and founder of the International Pain Foundation, and I've lived with algoneurodystrophy for more than 25 years. As a patient advocate, author, and speaker, I'm here today to voice my strong support for the proposed analgesics class update. The patient-centered plan gets it right. It promotes multimodal care that combines the best non-opioid therapies with non-drug approaches while keeping opioids available when they are truly needed for complex conditions like neuropathic pain, cancer pain, sickle cell disease, and end-of-life care. I especially support individualized care for each patient decided by the medical provider and continued access to non-opioid options such as Gervanex and Suzetrigine, for acute pain, shared decision-making, documented functional improvement, PDMP checks, and naloxone co-prescribing. I have felt both the benefits and the risks of pain treatment over the years. One-size-fits-all restrictions only cause more suffering, loss of function, and higher health costs. You need to balance flexible approach and both protect the safety and access for the patients in need. I respectfully urge you to adopt these updates. Patients like me are counting on you. In the future, I would also suggest individualized care options such as pharmacogenomics testing and treatments like IV ketamine and IVIG. Thank you for listening to the patient voice, and I'm happy to answer any questions.
Thank you, Barbie. Any questions from the committee? All right, again, thank you. And we also have Amy Adelman with A2A Consulting. Also requested by Vertex to be in attendance. With that, are you able to unmute your line?
Yes, I'm here. Thank you.
The floor is yours.
Thank you. Thank you so much to the Pharmacy and Therapeutics Committee for having me here to provide my public testimony or public comment. I'm a patient advocate, and as a rare disease and two-time kidney recipient, I know pain management is not optional. It is essential for healing. Transplant patients cannot take NSAIDs and often require individualized pain plans. Yet, when patients seek safer, non-opioid options, they face insurance barriers, prior authorization requirements, step therapy, and higher out-of-pocket costs, while opioids remain the easiest and most accessible choice. That imbalance puts patients at risk. In 2025 alone, more than 400 transplants were performed here in Oregon. Each of those patients deserve the opportunity to learn about and access non-opioid pain management options without unnecessary financial or administrative hurdles. Oregon's pain parity law, Senate Bill 598, addresses these directly by requiring insurers to apply the same coverage standards to non-opioid pain treatments as they do to opioids, eliminating policies that inadvertently steer patients toward more addictive medications. Millions of Americans become persistent opioid users each year following surgeries, and often safer alternatives were unavailable or unaffordable. Expanding equitable access to effective non-opioid treatments is a practical and upstream solution to reduce misuse, prevent addiction, and save lives. Thank you so much for my testimony.
Thank you, Amy. Any questions from the committee for Amy? All right, again, thank you for your time. I did have one additional person that requested time to provide public comment. I'm not seeing them in the audience today. It is Kathy Sapp with the American Chronic Pain Association. But I'm not seeing their attendance, so we'll not be able to call upon them. All right. So we'll turn it back over to Sarah. We'll go through the recommendations one more time and prepare for a vote.
So the recommendations are to update the opioid, NSAID, and muscle relaxant prior authorization criteria to align with current evidence, and then to evaluate costs in executive session.
Any discussion from the committee?
I move for approval of the recommendations for all the prior authorization criteria.
Thank you, Doug.
Can we get a second?
Second.
Thank you. All those in favor?
Aye.
Aye.
All those opposed? Abstained? Thank you.
All right. Next, if you're following in the packet, turn your attention to page 82. We have a new drug evaluation, and Deanna, turn it over to you.
Thanks, Roger. So we're going to be talking about this new drug, elanzanetant. If we could go to the next slide. This is a dual neurokinin 1 and neurokinin 3 receptor antagonist that was approved last October for the treatment of moderate to severe vasomotor symptoms that are associated with menopause. The recommended dose is 120 milligrams or 2 capsules once daily at bedtime. This medication is similar to vesolintant, but vesolintant only inhibits neurokinin 3. Of note, for vesolintant, the FDA has issued a black box warning regarding the rare but serious risk of hepatic injury that was observed in post-marketing case reports. So if we could go to the next slide. So in terms of what's recommended to manage hot flashes or vasomotor symptoms, the American College of Obstetrics and Gynecology, as well as the North American Menopause Society and Endocrine Society, they all recommend systemic menopausal hormone therapy, either estrogen combined with progesterone in patients that have a uterus, or estrogen alone in patients without a uterus as first-line treatment for vasomotor symptoms. Contraindications to estrogen include a history of uterine cancer, hepatic disease, or venous thromboembolic event. The FDA did revise the black box warnings for estrogens last November, and they removed the risk statements about the risk of cardiovascular disease, breast cancer, or possible dementia that are associated with the use of estrogen. We do have non-hormonal treatment options that are also available in those patients that have contraindications to hormone therapy, or if they prefer to not receive hormone therapy. So the recommendations from a 2023 position statement from the North American Menopause Society includes SSRIs, SNRIs, gabapentin, and oxybutynin. The selective neurokinin receptor antagonists are an emerging class of non-hormonal therapies that have been studied to relieve vasomotor symptoms. And I talked about the mechanism of action in the background. Basically, hot flashes originate in the thermoregulatory center of the hypothalamus. And if you inhibit the neurokinin receptors that are in that area of the brain, it leads to unopposed activity of the thermoregulatory center, which results in hot flashes. So the neurokinin antagonists inhibit that process. If we go to the next slide, just to review in terms of clinically meaningful endpoints when we look at menopause therapy. So a decrease in the frequency of vasomotor symptoms, at least 2 hot flashes per day or 14 per week, or a decrease in the severity of the vasomotor symptoms, so at least 50% reduction on a 3-point scale. So the next slide talks about the 2 trials that the FDA looked at for clinical efficacy of this new therapeutic entity. So they were both double-blind, placebo-controlled, randomized controlled trials over 26 weeks. And interestingly enough, the placebo arm only received the placebo for 12 weeks, and then they switched everyone to elanzanetant for the last 14 weeks of the study. The enrollment was very similar in both OASIS 1 and OASIS 2. The patients had to have at least 50 hot flashes per week. That was one of the major inclusion criteria, and then they excluded people with the histories that are outlined there on the slide. So the co-primary outcomes were the least square mean change in vasomotor symptom frequency per day from baseline to week 12. And that was statistically significant in both studies. And then also the least square mean change in vasomotor severity, that was statistically significant. But in terms of the clinically meaningful effect, as I mentioned in the previous slide, generally a 50% reduction is considered clinically significant, and that was not met in either one of these studies. We could go to the next slide. The trial limitations, it only included postmenopausal individuals and women that had vasomotor symptoms due to perimenopause, or if they were getting endocrine therapy for breast cancer, were excluded. Most of the participants were white, very limited Black and Latino enrollment. And then it's a subjective nature in terms of how the vasomotor symptoms present and the accuracy of recording the event, because the outcomes were all based on patient-reported diaries. So that may have introduced bias, which might explain the strong placebo response that was seen in these trials. Of note, there are 2 long-term trials that were currently going on. So the OASIS 3 trial enrolled postmenopausal women, and it was long-term. It was designed to provide long-term safety data at 52 weeks. Unlike the OASIS 1 and 2 trials, there was no requirement for a minimum number of vasomotor events per week. And they did show significant changes in both the event frequency and the severity in that trial. And then OASIS 4, women aged 18 to 70 years with moderate to severe vasomotor symptoms who were receiving endocrine therapy, so either tamoxifen or aromatase inhibitors for hormone receptor breast cancer, were enrolled in this trial, and it also showed significant results. It is not FDA approved for these individuals, but I think the manufacturer was just looking to see if they could broaden the population that might be eligible to get this drug. The next slide summarizes the clinical safety, and headache was the biggest side effect, but fatigue, dizziness, and somnolence were also very prevalent. So for this reason, that's why the drug is recommended to be taken at bedtime, and patients should be advised about the potential for feeling sleepy or drowsy, and they should make sure that they don't drive or engage in hazardous occupations until they know how they respond to this therapy. These were the adverse events reported in that long-term trial. Other things to be aware of, I mentioned fezolinetant has the hepatic screening, and they did notice elevations in serum ALT and AST concentrations in the OASIS trials. So it's recommended to attain baseline LFTs prior to starting this drug. And then it's not recommended for use in patients that have end-stage renal disease or if they have moderate to severe hepatic impairment. Because it is metabolized through the CYP3A4 hepatic enzymes, there's a number of possible drug interactions, either with CYP3A4 inhibitors or inducers. Moderate or strong inhibitors, grapefruit juice, and then again, strong to moderate inducers. If the drug is co-administered with moderate inhibitors, the dose of elenzanetant should be reduced to 60 milligrams once a day. And then animal studies show that it can cause negative impacts on pregnancy or stillbirth. And generally in our postnatal population, we wouldn't expect them to be pregnant, but it's just a warning that's included in the manufacturer's prescribing information. So the recommendations are summarized on the next slide. Thanks, Sarah. So instead of just having fezolinetant be by itself, we'd like to create a PDL class called the neurokinin receptor antagonists and include both fezolinetant and elenzanetant in that class. and continue to designate elanzanitant as non-preferred on the PDL to make sure that it's being used in the appropriate populations. We go to the next slide. This just summarizes the changes to the PA criteria, which begin on page 95 if you're following along in the packet. So again, we're going to revise the title of the criteria to say neurokinin receptor antagonist, and then we would add elanzanitant to that list. On the next slide is just a summary of, we would like to document the baseline frequency and severity. You can see that highlighted in green for question 3. And then for question 6, we just called out fezolinetant separately because they have slightly different prescribing guidance based on what they've been seeing with the post-marketing reports for fezolinetant. So we go to the next slide. So for fezolinetant, we would look to make sure that they've got baseline hepatic function and renal function. And then for elanzanitant, same thing. Are they have they looked at baseline labs? Are they taking any drugs that might interact with the elanzanitant? And if they're taking a moderate CYP3A4 inhibitor, has the dose been reduced? And then, if they have any of these contraindications, we would not approve therapy. We go to the next slide. This is a renewal criteria, and we just modified taking out severe cirrhosis and replacing that with hepatic injury. So, with that, that's the recommendations again, which I mentioned earlier. Are there any questions from the committee about the review or the changes to the PA criteria?
Nice job, Deanna. We don't have anybody that's requested public comment for this topic. Again, any questions from the committee? Or we'll entertain a motion.
Move for approval of the recommendations on prior authorization as outlined.
Is there a second? Thanks, Doug.
Second.
Okay, all those in favor? Aye.
Aye.
All those opposed? Abstain? All right, thank you.
Great. Again, following along in the packet, draw your attention to page 99, and we'll turn it over to Sarah Fletcher.
Thanks, Roger. The next topic on the agenda is a DERP summary, or a Drug Effectiveness Review Project summary on pharmaceutical treatments for hereditary angioedema. It's for the prevention and treatment of attacks. Now, the purpose is to summarize the findings of effectiveness and potential harms for hereditary angioedema for prevention and treatment of attacks. This class was last updated in 2021, and there have been 3 new agents approved since then. I have them bolded in the table below, and you can see the top part are the agents that are approved for acute treatment, and then the lower half are the agents that are approved for prophylaxis. And the ages vary for their indication, as well as some routes of administration that vary. If you can go to the next slide. So DERP is an outside organization that we consult with, and they did a review looking from through June of 2025 for comparative evidence. They had 22 randomized trials. None of them were comparative. They're all placebo-controlled, and most of those were included in the previous P&T review. I'm going to go through the ones that were not, and most of those are associated with the approval of the 3 new agents. Additionally, there are 2 expanded indications, and then there's 1 fair quality guideline. If you can go to the next slide. One of the new agents that has been approved is sebetralstat, or Ekterly. It's approved for acute attacks in those 12 and older, and it is an oral tablet. It's the only oral tablet for acute treatment of attacks. It was approved based off of 2 studies. More details are available in the DERP summary, but one was a phase 2 trial, one was a phase 3 trial. There was low risk of bias in the phase 3 trial that had 136 patients, and they pulled results, so they look a little bit different than how we normally present our results. But from the DERP summary, there was a quicker initial and sustained improvements in symptoms, including the complete resolution of symptoms. That was based off of low certainty of evidence, so it's not something that they're super certain about based off of the quality of the evidence that we have. There's less use of on-demand rescue medications. There was a significantly shorter time to symptom relief for those receiving 300 or 600 milligrams. And that was compared to placebo, where it was about, 1.79 hours or versus a placebo of 6.72 hours. And it's unclear if it's associated with a higher risk of adverse events with short-term use. 37% of patients had one adverse event, and most of those adverse events were fairly mild, including things like headache, nausea, dyspepsia. If you can go to the next slide, another of the new approvals is DAWNZERA, and this agent is approved for prophylaxis in those over 12 years old. It is a subcutaneous injection. It was also approved based off of 2 trials, a phase 2 and a phase 3. The phase 3 had 91 patients in it, and they did see a reduced rate of attacks from 2.25 per month to less than half of 1 per month. It also had a demonstrated clinical response of 65 to 82%. And something we don't always see is they did see an improvement in the angioedema quality of life, a score by 18 to 20 points, and 6 points is considered clinically significant. The adverse events were generally mild, and they had no severe adverse events reported in those trials. And now if you can go to the third new approval, this is ADEMBRY. It was also approved in 2025, and it is also for prophylaxis in those over 12 years old as a sub-Q injection. It was approved based off of 2 randomized control trials versus placebo, again, a phase 2 trial and a phase 3 trial, both of them under 100 patients. The monthly attack rate here was reduced by about 87% in the phase 3 trial and 100% in the smaller phase 2 trial, with a 92 to 100% response rate from baseline. Now, for attacks that were requiring on-demand treatment, there was a mean of 0.23 attacks with the active treatment compared to 1.86 attacks with placebo. And again, the adverse events were mild, and there were no severe adverse effects reported during the study. And lastly, we have the new indications. There are 2 medications that have expanded indications down to age 2. One is for ATAK-0, and it is for the prevention of HAE. There were also 2 new studies that were published in the DERP summary. One was an observational study, which we don't include as high quality, and one was the Caspian study, which was not used in the new approval, but I think it's interesting because it's a 26-week trial evaluating the 300 milligram every 2-week dose in patients who are 12 or older. But these patients had a previous attack, but a normal C1 inhibitor function. So it's not your normal HAE patients. Patients with HAE type 1 generally have a decreased C1 inhibitor function level. Based off of this, the model attack rate was actually not significant compared to placebo. There are 2 other studies with a more generalized population, and those were, they did have statistical significance, but this one did not. Most of the patients did report adverse events, but most commonly it was injection site pain. And then the other additional new indication is for Orladeyo, which is for patients, again, down to 2 years old for the prevention of HAE. And there's a new oral pellet formulation for those younger patients. If you can go to the next slide. There was one guideline that was published. It was only a fair quality, so it's only presented here for clinical context. We wouldn't have included it if it was a review that DERP was doing de novo versus one that's in the DERP summary. And some of the issues were the systematic presentation of the results and conflicts of interest. But you can see for acute treatment, they generally recommend C1 esterase inhibitors, acalabant, icatibant. For prophylactic therapy, again, the C1 esterase inhibitors, and then they have some additional patient populations where these older agents are, again, the preferred agents. But this guideline was done in 2022, which is before the 3 new approvals took place. Now, if you can go to the next slide, we have alterations to the PA criteria. There were no changes in the initial page, and I do just want to note on the requires PA, this policy does not apply to emergency departments visits or hospitalizations. If you can go to the next slide, there is a table at the beginning of the chart that has all of the approvals, their ages of approval, and the dose and frequency. And I've added the new agents and the expanded indications. One of the expanded indications was already added prior to this review. And then additionally, I have one more change to PA criteria. This was not in the final posting. This is something that I wanted to present today after we looked at the class a little bit more. As this is becoming a more mature class, we do have preferred agents both for acute and prophylactic treatment. And previously we had a step through that just asked, will you change to the preferred treatment? But given that we have more historical evidence with some of the older agents, I wanted to add a step through of if the request is for a non-preferred agent, is there documentation of lack of benefit or contraindications, or are there extenuating circumstances necessitating the need of a non-preferred product? And so I wanted to present that for your consideration here as well today. You can go to the next slide. The recommendations are just to update the PA, and then we will review the costs in executive session.
Nice job, Sarah. Any questions for Sarah? All right, hearing none, we did have a last-minute request to provide public comment. We have Jeff Martin from BioCryst. Are you able to unmute your line?
Yes, I am.
Okay, the floor is yours.
Great, thank you. Good afternoon, everyone. My name is Jeff Martin, and I'm with BioCryst Pharmaceuticals. Thank you for the opportunity to present information on Orladeyo or berotralstat for the prophylaxis preventing attacks of hereditary angioedema or HAE. All approved dosing and safety information can be found at orladeyohcp.com. Orladeyo is an oral capsule that is taken once daily in patients 12 years of age and older, and recently approved the pediatric patient formulation for patients 2 to less than 12 years of age. As Sarah mentioned, the World Allergy Organization and European Academy of Allergy and Clinical Immunology guidelines recommend berotralstat as a first-line option for long-term prophylaxis in HAE. These guidelines included key opinion leaders from the United States in addition to European experts. The Cochrane collaboration has also concluded that there is not enough clinical trial data available to give clinical preference to any of the available options for long-term prophylaxis in HAE. Recently published studies for berotralstat demonstrated 90.8% reduction in monthly attack rates at 24 months, also reductions in on-demand medication use, and significant decreases in healthcare resource utilization, including hospitalizations, emergency room visits, and outpatient visits. Patients on berotralstat have also reported improved treatment satisfaction and quality of life. Importantly, berotralstat has shown effectiveness across HAE types 1 and 2 and HAE with normal C1 esterase inhibitor. As mentioned, BioCryst recently got approval for the new oral pellet formulation for patients 2 to 12 years of age. This should be commercially available soon. This will be the only oral option for this patient population and will allow these patients to avoid the injections necessary for the other long-term prophylaxis products, which are administered from between 2 times per week to 2 times per month. In conclusion, we respectfully request that the committee consider berotralstat for a preferred position on the Oregon Medicaid formulary without requiring failure on other LTP agents within this category. As the only once-daily oral long-term prophylaxis for HAE, berotralstat offers demonstrated safety and efficacy while reducing healthcare resource use and improving quality of life. Thank you for your time, and I'm happy to address any questions you may have.
Any questions from the committee for Jeff? All right, hearing none, we'll put the recommendations back up.
Great, thank you.
So again, the recommendations are to update the PA criteria as amended with the proposal from Sarah today. And we're going to review costs in executive session. Discussion or a motion to approve?
Motion to approve.
Appreciate it, Pat.
Is there a second?
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
All right. Thank you all. Next up, we have the GnRH agonist and antagonist class update found on starting on page 111 in the packet. And Deanna, we'll turn it back over to you.
Thanks, Roger. Yep, this is our second women's health topic for this meeting. The RH analogs are the gonadotropin releasing hormone analogs. For the rest of this talk, I'll just talk about GnRH. And the focus is on pelvic pain and dysmenorrhea. We go to the next slide. The purpose for this review is to make sure that we confirm that the OHP fee-for-service policies align with HERC guidance for these conditions. And with the benefit plan update, some of the previously unfunded conditions will be funded, so we wanted to make sure there was a pathway to treat. If we go to the next slide. This is the HERC guidance for dysmenorrhea. I highlighted what the HERC guidance has. So basically, for dysmenorrhea, they require a 6-month therapeutic trial with hormonal therapy and non-steroidal anti-inflammatory drugs. And you can see the GnRH analogs are mentioned as one of the agents for treatment of dysmenorrhea. And then the next slide summarizes the guidance for pelvic pain syndrome. And once again, similar guidance in terms of what medications that they want patients to try before they advance to surgical options. So we just wanted to make sure our criteria aligned with this HERC guidance in particular for these requirements. We go to the next slide. So this is just a summary of the medical management for endometriosis. And of course, the hormones, combined estrogen, progesterone, contraceptives are the preferred drug of choice. Danacrine is kind of fallen out of favor because of its adverse side effect profile. But you can see that the agonists, leuprolide, goserelin, and nafarelin are recommended for endometriosis. And then also the antagonists, we have two. We have elagolix and relagolix, and we've reviewed those previously in our P&T committee meetings. If we go to the next slide, these are the recommendations for medical management of fibroids. And once again, combined estrogen progesterone therapy is recommended, or using an IUD that releases levonorgestrel or a Mirena IUD. Tranexamic acid is sometimes recommended for excessive bleeding. And then the progesterone receptor modulators are not approved by the FDA. Mostly because of hepatic toxicity and for other reasons. And then at the very bottom, you see our GnRH agonists and antagonists, the two antagonists, and then leuprolide also. Go to the next slide. In terms of what kind of evidence that's been published since our recent reviews, there was 2 systematic reviews from Cochrane. In 2025, Cochrane evaluated progesterones in the treatment of endometriosis-related pain, and oral progestins compared with placebo. There was moderate certainty evidence that they reduced overall pain and dysmenorrhea. And then compared with other hormonal suppression strategies such as oral contraceptives or the GnRH agonists, the evidence for progestins was less certain because there was a small number of studies for each comparison and outcome. 2023 Cochrane review specifically looked at the GnRH agonists, so goserelin, leuprolide, nafarelin, and triptorelin in the treatment of painful symptoms associated with endometriosis. And for relief of overall pain, there seemed to be a slight decrease in favor of pain associated with the GnRH agonist compared to placebo or oral or injectable progesterones. And then the effects on alleviating pain were uncertain when they compared the GnRH agonist with danazol or a progesterone IUD. That was very low certainty evidence. For systematic reviews for fibroids, there was a 2025 Cochrane review that looked at the benefits and risks of medical treatments prior to surgery, and pretreatment with the GnRH analogs may reduce the uterine and fibroid volume compared to placebo, which makes the surgery a little bit easier, and it might also increase pre-op hemoglobin levels, but they also increase the risk of adverse events. The Cochrane review also noticed that blood transfusions and operation time during hysterectomy may be reduced with pretreatment with the GnRH analogs compared to placebo. That was low certainty evidence. We get into the guidelines on the next slide. So the Society of Obstetrics and Gynecology in Canada issued guidance for management of primary dysmenorrhea, and starting with nonsteroidal anti-inflammatories or acetamin as first line, administered with regular dosing regimens, not PRN. And then also continuous or extended use of combined hormonal contraceptives are recommended for treatment of dysmenorrhea. The next slide, Canada's Drug Agency recommended that the combination of relugolix with estradiol and norethindrone be reimbursed for management of heavy menstrual bleeding associated with uterine fibroids. And they also, NICE supports that as well for the management of fibroids and endometriosis in women of reproductive age. Go to the next slide. The European Society of Human Reproduction and Embryology had issued guidance for management of endometriosis, and they updated that in February of 2022. And again, starting with nonsteroidals or other analgesics to reduce pain. They rated that as a weak recommendation based on very low quality evidence. And they also recommend combined hormonal contraceptives. They do recommend GnRH agonists, although at the time of the update, there was limited evidence regarding the dosage or duration of treatment. And then it's also recommended to prescribe hormonal add-back therapy after GnRH agonist treatment to prevent bone loss. And they also recommended GnRH antagonists to reduce endometriosis-associated pain. Again, they had limited evidence in 2022 when they were doing this update. All right. So our recommendations are no changes to the PDL based on recent published guidelines and systematic reviews. We would like to modify the PA criteria for the GnRH agonists and GnRH antagonists to align with HERT guidance, and we'll look at drug costs in exec session. So the first change for the PA criteria, which start on page 135, we just split question 8 into 2 questions. Are they of childbearing potential or pregnant? Because that aligns with our other PA criteria that does this assessment. Next slide. So question 13, we just modified the verbiage to say, is it for management of moderate to severe pain associated with pelvic pain or endometriosis? That aligns with the HERT guidance. And then question 14, we updated the trial of using either contraceptives or progesterones or an IUD to 6 months. I think before that we had it as 3 months. So this just aligns with the HERT guidance, and it includes all types of hormonal products. So we added the ring, patch, and the implant to that question as well. And then finally, for the GnRH antagonists, we just revised question 5 to align with HERT guidance, and we put moderate to severe pelvic pain associated with endometriosis in that VA criteria. So those were the changes that we had. And if we go to the next page, I think it's just a summary of the recommendations. Are there any questions from the committee based on these PA changes?
Nice job, Deanna. Doug, you have a question?
I move for approval of the PA criteria.
Well, that's even better than a question.
I'll second it.
Wonderful. All those in favor?
Aye.
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 Any opposed? Abstain? All right. Thank you, everyone.
All right. Moving right along. Again, if you're following the packet of materials, draw your attention to page 143 for the Wescara orphan drug evaluation. And Sarah Fletcher, we'll turn it back over to you.
Thanks, Roger. Again, this is the Wescara Orphan Drug Evaluation. If you go to the next slide, The purpose of this is to review safety and effectiveness and provide prior authorization criteria. Wiskira is an HIV-based lentiviral vector gene therapy, and it's used after myeloablation in pediatric patients 6 months and older who have something called Wiskott-Aldrich syndrome and have a mutation in the WAS gene, and they are ineligible for a stem cell transplant because there's no suitable donor. This medication is also part of the high-cost drug carve-outs that we have where certain medications are carved out to fee-for-service in very rare, very expensive conditions that that the OHA has identified. If you can go to the next slide. Wiskott-Aldrich syndrome, or WAS, it's quite rare. The estimates range, but it could be as much as 1 to 4 per million male live births. It's an X-linked disease on the WAS gene, and it affects the protein expression. And those who have completely absent protein expression generally have severe disease. Those who have partial protein expression can have varying severities of the disease. There are milder forms called X-linked thrombocytopenia that can actually occur in women. Most of those with severe disease are diagnosed as young children and infants. They present with eczema, thrombocytopenia, and multiple infections, bacterial, viral, and fungal. And there's also a higher risk of autoimmune diseases and cancers as time goes on. Those who have severe disease and don't get a stem cell transplant, survival is the early teen years. So it's a pretty severe condition. There are some scoring systems to help quantify the severity and predict those who could benefit from things like a stem cell transplant. One of those is called the ZOO scoring system. It's a 0 to 5 rating, and those who have scores of 3 and above are generally have severe diseases and more severe mutations. The mild to moderate versions of the disease treatment is usually supportive care, things like treatment of the eczema, treatment of the infections. But those who have severe presentations are referred for the definitive therapy with a stem cell transplant, or when there's no donor, now we have this gene therapy that's available. So if you go to the next slide, this medication was approved based off of 2 single-arm studies and an expanded early access program that was pooled and evaluated by the FDA. So like many of the gene therapies, it's open label and single arm, and the comparator was historical pre-treatment outcomes. There were only 27 patients. The median age was 2.5 or 2.6 years, and it ranged down to 11 months to 35 years. There was one death in the cohort, and it was the 35-year-old, which, based off of the previous slide, is quite outside the normal range for this condition. All of the patients were male. Most of them were white. Most of the studies were conducted, or most of the patients were from Italy. They all had thrombocytopenia. Most of them had eczema. And then that ZOO scoring system that I mentioned, a score of 3 or above, was in almost all of the patients, 92.5%. They included patients who did have a mutation, and they either had absent expression of the protein, or a severe mutation, or a severe clinical phenotype as defined by that ZOO clinical score. And then they didn't have a matched donor available. And then patients who were excluded are those who had HIV, certain neoplasms already, myelodysplastic syndrome, and then other conditions that might make them ineligible for myeloablation. The duration of follow-up ranged pretty significantly, but it was 1.2 to 13.3 years in the 26 surviving patients. If you can go to the next slide, the efficacy outcomes, the severe infections in the 6 to 18-month period after the infusion versus the 12 months pre-treatment was a change of 2 to 0.2 infections per patient per year, which is a pretty significant change. And then the rate of moderate to severe bleeding episodes in the 12 months after infusion versus the pre-treatment period was 2 down to 0.8. If you go to the next slide, as you can probably see from the description of the trial itself, there are some pretty big limitations. It's not randomized, single arm, open label, and it's a pretty small sample size. But also, based off of some of the information I found in the FDA review, this was not originally designed for efficacy testing, and the historic comparative data was implemented post hoc, and there was retrospective and incomplete data collection on those historic controls. So that can certainly affect our outcome data. The full protocol and results are not yet published, and most of the participants were in Italy and not the United States. If you can go to the next slide. As far as clinical safety, I mentioned that 1 patient did pass away. It was due to deterioration of a pre-existing neurological condition pretty soon after the administration of the medication. And then 21 of the patients experienced a serious adverse events, but most of those were due to the myeloablation. And we, again, didn't have a comparison group. Go to the next slide. I do have PA criteria developed for this. It is a one-time gene therapy, and in the covered populations, you can see it's a carve-out, so fee-for-service and CCO patients beginning back in February when this was added to the list. In the next slide, So we have it on question 2, is this the approved age and indication? And then question 3 is requiring a specialist. Question 4 is a genetically confirmed WAS mutation. And then question 5 is to look at the severity versus someone who has a less severe version of the disease. So do they have a disease clinical score of 3 or higher than I mentioned, or a severe mutation, which I've defined based off of mutations I found in the FDA summary and then an additional publication, or absence of the WAS protein expression, which again, the definition of that, it was pulled from the FDA summary. If you can move to the next slide, documentation that there is no suitable stem cell transplant recipient donor. And then lastly, these are the contraindications from the package insert. And if the patient meets these criteria, we would send this to the medical director for a secondary review, which we're doing with all of the high-cost drug carve-outs. So, are there any questions that I can answer about this one?
Nice job summarizing, Sarah. Any comments or questions? We do not have any public comment for this topic, so if there are no questions, we'd entertain a motion.
Motion to approve.
Is there a
Thank you,
second?
Doug.
Second.
Thank you. All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
All right, we're a little ahead of schedule if you're following along with the pack of the materials, but nonetheless, I think let's take a quick 15-minute break right now, and we'll reconvene for the last 3 topics before executive session. So I am gonna start my timer, and we'll see you back here in 15 minutes. All right, I hope that break was sufficient for everybody. We're back on the recording. And next up, we have the Myolept orphan drug evaluation, and that starts on page 153 in the packet. And Deanna, back on over to your able hands.
All right, thanks, Roger. So Sarah did a nice job discussing why we're reviewing these orphan drugs. This is another drug that falls in the high-cost drug category. So if we go to the next slide, we're going to look at the evidence for the safety and effectiveness of metreleptin in people with lipodystrophy due to leptin deficiency. And then we've developed PA criteria to support medical appropriateness and necessity for the use of this drug. We go to the next slide. So I went through a lot of the background, but these are just the highlights. So leptin is a naturally occurring hormone that's predominantly secreted by adipose tissue, and it plays a central role in the regulation of energy homeostasis and fat and glucose metabolism. Lipodystrophy syndromes due to leptin deficiency are rare, and they're categorized by complete or selective deficiency of body fat. So instead of being stored in the adipocytes, the lipids are stored in the liver and muscles, which results in diabetes, insulin resistance, and metabolic comorbidities like hepatic steatosis or hypertriglyceridemia. Another important facet of this condition is the lack of leptin can also lead to hyperphagia or constant hunger, which also contributes to the metabolic abnormalities. The lipodystrophy syndrome can be classified as autoimmune or acquired, and some of the autoimmune disorders include dermatomyositis, autoinflammatory disorders, tissue-specific autoimmunity, and myeloid disorders that lead to the acquired form of the lipodystrophy, or it can be congenital. And then it also can be subclassified as either generalized or partial. So partial lipodystrophy is associated with a range of leptin levels, and it may or may not be accompanied by metabolic disease, where the individuals that have the generalized form generally have more severe disease. In the Oregon Health Plan, we had 62 people that had the diagnosis of lipodystrophy in the past year. Most of the patients were enrolled in a CCO, and 5 of them were enrolled in fee-for-service. So if we go to the next slide, metroleptin is a recombinant analog of leptin, and it differs by 1 amino acid compared to native human leptin. It's dosed based on weight and gender, and is the only medication that's approved by the FDA as an adjunct to diet as replacement therapy in patients that have congenital or acquired generalized lipodystrophy. And I'm going to emphasize generalized because that's the only patients for whom the FDA has approved the use of this drug. If they have partial lipodystrophy, it is approved in the European Union for people with partial lipodystrophy, but according to the FDA, the effectiveness in this patient population has not been established. The annual wholesale acquisition cost for this drug is over $1 million when it's supplied as the 11.3 milligram vial. But since the dosing is weight-based, the cost may vary depending on the dose for which the patient is prescribed. Women tend to have higher leptin levels than men, even after adjustments for differences in body composition. So that will be reflected when we look at the studies that the study that they use to evaluate the safety and efficacy for this drug. There are some guidelines. So Canada's Drug Agency in 2024 recommends metroleptin as an adjunct to diet as replacement therapy. And they have approved it in both types, the generalized and the partial lipodystrophy. And there are other names for these conditions that are outlined there on the slide. And they're very specific that it's recommended if they have the generalized lipodystrophy and at least one metabolic abnormality, so either diabetes, insulin resistance, or high levels of triglycerides. And then in the people with partial lipodystrophy, the age is a little bit higher, and they have established some guidance for what threshold is for A1C or triglycerides. NICE has also come out with some recommendations that are very similar to Canada's Drug Agency. And because these organizations tend to follow European guidelines, that's why they have issued guidance for people with partial lipodystrophy. If we go to the next slide, the clinical trial that the FDA used to support the approval of this drug is now published. However, study details are included in the prescribing information for that particular study. The phase 2 published clinical trial to support the safety and efficacy is described and evaluated in Table 1 on page 157. It was an open label, single site, single arm study conducted over 14 years at the NIH, and it enrolled 66 adults and children only with the generalized form of lipodystrophy. Most of the patients were in their teenage years. They were mostly female, which reflects the prevalence of the condition. And then they subdivided how many had the congenital form, which was most of the patients, versus the acquired form of the generalized lipodystrophy. And then the mean baseline metabolic disorders that they had, so they had an elevated A1C and elevated fasting triglyceride. So that was their main inclusion criteria, was they had to be 6 months or older with a diagnosis of generalized lipodystrophy and at least one metabolic disorder. So the co-primary outcomes were the change in A1C from baseline to 12 months, and that showed a significant lowering in A1C over 12 months, and then a % change in fasting serum triglycerides at 12 months, and that also showed a statistically significant change in the triglyceride levels. We go to the next slide. Again, there's a lot of limitations to this trial. It's a single-arm, open-label study designed in a small number of patients with the rare condition of generalized lipodystrophy. The population was mostly female, which reflects the prevalence of the condition. There were a large number of dropouts and missing data, and they used the last observation carried forward to impute missing results that were 6 months post-baseline assessments. And the primary efficacy outcomes were surrogate metabolic endpoints, either the change from baseline A1C and the fasting triglycerides. This trial didn't show any evidence that the metroleptin helped improve the hyperphagia associated with this condition or health-related quality of life changes. If we go to the next slide. The most common adverse events were weight decrease, abdominal pain, low blood sugar, headache, and decreased appetite. I want to point out that the label does carry 2 black box warnings. T-cell lymphoma has been reported in patients that have the acquired generalized lipodystrophy, both in people that have been treated and untreated with metroleptin, and then antibodies can form with neutralizing activity to this drug in patients that have been treated with the drug. So for these reasons, it's only available through a REMS program, the Restricted Evaluation and Mitigation Strategy Program, because of the risks associated with developing the antibodies and the risk of lymphoma. Of note, patients that have HIV-related lipodystrophy, non-alcoholic steatosis, NASH, or I think now it's called metabolic steatosis or MASH, and obesity or metabolic disease that's not associated with leptin-deficient lipodystrophy are not approved for metroleptin therapy. So our proposed PA criteria begin on the next slide, which are on page 160 of the packet, if you're following along in the packet. So we just want to promote evidence-based standard of care in patients that are diagnosed with lipodystrophy due to the leptin deficiency and limit it to populations in which it's been approved by the FDA. And it'll be for fee-for-service and CCO. So that's okay. Sarah, you were fine going to the next slide. So our standard PA criteria, we ask what the diagnosis is it for the FDA-approved agent indication? And then question 4, we just kind of highlighted any of the indications that are not approved, including the partial lipodystrophy patients to use metroleptin therapy. And then on the next slide, so we want to make sure it's prescribed by an endocrinologist or someone that has experience in managing lipodystrophy and leptin deficiency. And then we want to make sure that they have baseline assessments documented prior to starting the therapy. And then do they have persistent, a metabolic condition, either persistent hyperglycemia or and persistent hypertriglyceridemia. And then we also want to make sure that they've been optimized on appropriate therapy to manage the diabetes and to manage the high triglycerides prior to starting metroleptin. And then on the next slide is renewal criteria. So we've got it, if they meet the criteria, we will approve it for 6 months to see how they do. And then for renewal criteria, we want to make sure that they're adherent to therapy and that they're tolerating the therapy and that the provider has reevaluated their metabolic dysfunction and have we seen an improvement in either the A1C or the triglycerides? So with that, I will open it up to any questions from the committee.
Nice job, Deanna. No public comment. Any questions from the committee?
I move for approval.
Is there a second?
Second.
All those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
Okay, moving right along. Bring your attention to page 163 of the packet. We have a cephalosporin literature scan, and Kathy Centena, I'll turn it over to you.
Great, thanks, Roger. So yeah, today we're going to be talking about a literature scan that we did for the cephalosporins. We looked for new evidence for the use of cephalosporins and, oh, sorry. Okay, sorry, I thought someone was talking. Can you hear me okay?
Yep, hear you loud and clear. Go for it.
Okay, perfect. Okay, so we looked for first-line therapies based on bacterial resistance patterns and how those might have changed since we last looked at this class, as well as any recommendations that might be appropriate to change to the PDL. And so currently the cephalosporins that are preferred are cephalexin, cefprozil, cefuroxime, and cefdinifir. And I should mention that there is no the specific PA criteria for this class. The non-preferred drugs just go through the general non-preferred drug criteria. So there were 12 high quality guidelines identified for this review. First, we'll go over a quick background. Just as a reminder, cephalosporins are effective against gram-negative, gram-positive, anaerobic or aerobic bacteria. They're divided into 3 different categories, first generation, second generation, third generation, with the first generation having more activity against, of course, gram-positive and gram-negative, where the second and third have more activity against gram-negative. However, there is some coverage into gram-positives as well. So based on this review, the oral cephalosporins recommended as first line for certain disease states were for erythema migrans associated Lyme disease, cefuroxime was recommended first line. For severe cellulitis infection, cefuroxime was recommended first line. For recurrent cystitis in pregnant women, cephalexin or cefaclor was recommended first line. And then for community-acquired pneumonia in people with risk factors, cefuroxime and cefuroxime were recommended, as well as other antibiotics in combination, which we'll touch on in a minute. And then for mild diabetic foot infections and moderate to severe diabetic foot infections, cephalosporins were also recommended. So let's get into the guidelines. The first one is from the Infectious Disease Society of America, in which they published guidance in 2025 on the management and treatment of complicated urinary tract infections. And they recommended the use of IV cephalosporins for those with sepsis. And then those without sepsis, oral cephalosporins could be considered, although they were recommended as an alternative therapy as they weren't as well studied as some other treatment options. The second guideline was from the American Academy of Neurology, the American College of Rheumatology, and the Infectious Disease Society of America, in which they recommended treatment for the prevention diagnosis of Lyme disease. And here they did recommend the use of oral cefuroxime for erythema migrans and IV cefuroxime for patients that had any kind of neurological symptoms or Lyme carditis. And this was based on moderate quality of evidence. And then NICE also looked at recurrent urinary tract infections and then antibiotic prescribing for that. They did recommend cephalexin as an appropriate second-line agent for those requiring treatment for recurrent UTIs. This can be given as a single dose when exposed to a trigger or a daily dose at a little bit lower strength. Moving on, we have 3 more NICE guidelines. The first one is on bacterial meningitis and meningococcal disease, and they do recommend the use of IV ceftriaxone for most cases of bacterial meningitis and meningococcal disease. However, cefotaxime IV can also be used as an alternative for that condition. NICE also looked at using antibiotics for otitis media, and as we know, most time otitis media does not require the use of antibiotics, but if it is treated, then they recommend a narrow spectrum antibiotics such as amoxicillin. However, they did not find major evidence of treatment differences between the penicillin, cephalosporin, and macrolides, so those could be considered if needed as an alternative. Then NICE also looked at cellulitis and erysipelas in 2019, and they do recommend cefuroxime and ceftriaxone as options for the treatment of cellulitis if the infection is considered severe. Then 3 more guidelines. The next one by NICE looked at human and animal bite treatment recommendation. And if IV therapy is indicated, cephalosporins are recommended, usually as an alternative to amoxicillin, clavulanic, and the cephalosporins that they usually recommend are cefuroxime or ceftriaxone in combination with metronidazole. But of course, that's just for prophylaxis and treatment of a severe animal bite. And then NICE also looked at diverticular disease. Again, this commonly is not treated with antibiotics. However, in some patients that have comorbidities or they're immunosuppressed, they will recommend treatment in which cephalexin in combination with metronidazole can be used as an alternative option to, again, amoxicillin clavulanate. And then looking at urological infections, recently in 2025, the European Association of Urology evaluated antibiotics for treatments of all sorts of urological infections. So I refer you to page 169 if you want to look at all the recommendations. But in general, for cephalosporins, they do recommend their use in certain infections based on the infecting organism, the location, resistance patterns, and then, of course, adverse events, most commonly for things like cystitis, pyelonephritis, and urethritis. So 3 more guidelines that were looked at, one from the American Thoracic Society and the IDSA, in which they looked at the treatment of community-acquired pneumonia in 2019, and they do recommend cephalosporins, cefuroxime, and cefpodoxime in combination with other antibiotics such as macrolides or clarithromycin or doxycycline for those patients that require outpatient treatment for community-acquired pneumonia. Usually these patients would have risk factors such as diabetes or cancer. The IDSA also recommended guidance for the treatment of diabetic foot infections, and this was in 2023. They do recommend first-generation cephalosporins for the treatment of mild diabetic foot infections, as well as second and third generation cephalosporins for those with moderate to severe infections. And then in 2021, the CDC came out with recommendations for sexually transmitted infections. And in general, they recommend the use of ceftriaxone IM or IV for the treatment of all different types of gonorrhea infections. So in general, the recommendations are to make cefaclor and cefpodoxime preferred on the guideline or preferred based on the guidelines, and then to evaluate costs in executive session. If there's any questions from the committee, I'm happy to take those now.
Nice job, Kathy. No public comments, so any questions from the committee?
I move for approval.
Okay. Is there a second?
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
Fantastic. So for the last topic of the day, it starts on page 178 in the packet of materials, and we'll turn it back over to Deanna.
Thanks, Roger. All right, so we're going to evaluate new comparative evidence for the efficacy or harms of medications used to treat acne. If we go to the next slide, rosacea is currently not funded, but it will be funded with the Health Evidence Review Commission Benefit Plan update in 2027. So the evidence for rosacea treatments is also included in this drug class update. The acne drugs were last reviewed by the P&T committee at the February 2021 meeting, and Sarah did an outstanding job summarizing all the acne treatments. At that particular meeting, class code Terone, topical cream, was designated as non-preferred on the PDL. No other changes were made. The oral tetracyclines were last reviewed at March 2019, and after review, 2 recently approved tetracyclines, omadacycline and sarecycline, were maintained as non-preferred on the PDL. Sarecycline is in the guidelines, but it's no longer on the PDL because it's not eligible for federal rebates. So the preferred acne treatments include generic topical formulations of adapalene, benzoyl peroxide, clindamycin, dapsone, erythromycin, tretinoin, sulfacetamide, and oral isotretinoin. Single source brand formulations are non-preferred on the PDL because there's no high quality data to support their use in acne. In terms of the tetracyclines, the preferred oral tetracyclines are doxycycline suspension tablets and capsules and tetracycline tablets and capsules. We do have PA criteria for both classes of drugs. We just covered Legend topical medications that have FDA approval for acne and that are OHA funded for severe acne. And then the oral tetracyclines have a quantity limit to prevent inappropriate use beyond 2 14-day supplies in a 3-month time period. So use for all the medications is limited to the OHP funded conditions. If we go to the next slide, there wasn't a whole lot of high quality evidence. There was one systematic review for acne and 3 guidelines. And then for rosacea, there was 1 systematic review and 5 guidelines have been published over time. You will see when we talk about the guidelines, they're a bit dated, but that's all we had in terms of guidance for rosacea. So in 2024, the Cochrane Review evaluated the evidence on the efficacy and safety of topical therapies used for acne, and low quality data didn't show any difference between topical benzoyl peroxide, adapalene, or clindamycin. This 2015 Cochrane Review was the only systematic review I could find for rosacea. And the reviewers at that time found high quality evidence to support the effectiveness and safety of topical bromonidine to manage redness associated with rosacea. The effect of the bromonidine is short-lived. It only lasts a day and then the redness comes back. For the management of papular pustular rosacea, topical metronidazole, azelaic acid, ivermectin, or oral anti-inflammatory dose of doxycycline, in other words, 40 milligrams, tetracycline, and isotretinoin, they all appear to be effective and safe for short-term use. There's no clear evidence that any one of the treatments for papular pustular rosacea or any combination has an advantage over the other in terms of higher remission rates or fewer adverse effects. So if we go to the next slide, the NICE did review acne in 2023, and they recommend topical benzoyl peroxide combined with topical clindamycin for mild to moderate acne, and then combine topical adapalene and topical benzoyl peroxide, or topical azelaic acid combined with oral doxycycline for moderate to severe acne. The specific guidance is presented in Table 3 on page 188 of the packet. And then for any severity of acne, NICE does recommend topical adapalene combined with topical benzoyl peroxide or topical retinoids combined with topical clindamycin. But they stress not to use antibiotic monotherapy by itself or topical therapy plus oral antibiotics. Those are not recommended. Canada's drug agency did review that topical clascoterone cream, and they determined there's no comparative evidence to see how it stacks up to other acne treatments. So they did not recommend reimbursing in their plan in Canada for this topical agent. They did review a new triple agent that was recently approved by the FDA as well. It's a topical clindamycin, benzoyl peroxide, adapalene, and they recommend that it be covered as long as they can negotiate a reasonable pricing plan so that the cost of treatment with this triple agent doesn't exceed other topical therapies. Next slide, please. So in terms of rosacea guidelines, in 2019, the American Acne and Rosacea Society published rosacea management recommendations based on the evidence that they had available at that time. And they recommended using topical metronidazole or topical azelaic acid concurrently with oral doxycycline for severe rosacea, transitioning to just topical therapy after an adequate response is received. achieved. And then they also recommended topical brimonidine and topical ivermectin for treatment of rosacea that has diffuse redness of at least moderate severity. We go to the next slide. So these are more dated. In 2015, Canada's Drug Agency did recommend covering topical ivermectin for treatment of moderate to severe rosacea if the costs were reasonable. And because there was insufficient evidence of comparative efficacy with doxycycline 100 milligram, they did not recommend covering the brand name 40 milligram doxycycline. And then in 2011, they recommended covering topical azelaic acid gel for rosacea. At the time, azelaic acid and metronidazole, both were available, and I think they were similar in cost in 2011. We go to the next slide. In 2014, NICE reviewed the evidence for topical brimonidine gel, and they didn't actually issue any recommendations. They suggested it might be an option for adults that have moderate to severe rosacea and facial erythema, but they thought perhaps it would be best used in people that are particularly self-conscious about the redness, but because it doesn't last very long, they thought that it wasn't worth covering on their plan. And then in 2016, they looked at topical ivermectin for rosacea, and they did also not recommend any guidance for using ivermectin. And they said that usually it's treated with topical metronidazole or azelaic acid or oral antibiotics. So if we go to the next slide. There are 3 new formulations. So in 2021, the FDA approved a combination formulation of tretinoin and benzoyl peroxide, which is indicated for acne in patients that are over 9 years of age. And then I mentioned that triple combination, that triple topical combination the FDA approved in 2023, and that's approved in patients that are 12 years and older. And then there is a new oral formulation of minocycline, which is approved to treat rosacea in adults. So in terms of the recommendations, there's a few. So first, we want to make 1 or 2 generic topical metronidazole products that are approved for the management of rosacea preferred. So there's a pathway to treat. And then we would add the FDA-approved rosacea treatments to the preferred drug list for acne treatments and revise the title of the acne medications to be acne and rosacea topical medications. And then we would maintain those 2 new agents for acne as non-preferred in that class, and then also make that minocycline branded product non-preferred in the oral tetracycline drug class. No other changes are recommended. And then we would also like to revise the acne PA criteria to include non-preferred topical agents for management of rosacea, and then add a documentation of baseline assessment of disease severity. And again, revise the oral tetracycline PA criteria to include baseline assessments, and then add renewal criteria to the topical therapies and oral tetracyclines for continuation of these products in people with acne or rosacea. And then we'll look at medication costs in exec session. So here's what we did is we added question 3, which directs us to the renewal criteria, which we just added. And then on the next slide is the documentation for baseline assessment. And then we updated the tolerance to topical agents to be 12 weeks to align with the NICE guidance that we had looked at for acne. And then on the next slide is the renewal criteria. So is it for acne or rosacea? And then have the symptoms improved based on whatever baseline assessment the provider had used, either looking at the inflammatory lesion count or using some sort of scoring tool or looking at a quality of life tool. Or we just left it open-ended that maybe they used documented improvement using another assessment tool. Then for the oral tetracyclines, again, we added question 2, which just directs us to the renewal criteria. And then we added question 9 to ask if the antibiotic was being used for severe acne or rosacea. And if it is, we'd like to get a baseline assessment similar to what we developed for the topical products for acne and rosacea. And then on the next slide, I believe, is the renewal criteria. So we just want to make sure that if they're renewing an oral antibiotic for acne or rosacea, that they've improved on the therapy using those baseline assessments that I already outlined. So with that, I don't think we have any public testimony. Are there any questions from the P&T committee about this review or the changes to the PA criteria?
Nice job, Deanna. And to confirm, no public comment is registered.
All right, do we have a motion to approve?
Motion to approve.
Thank you, Doug. Do we have a second?
Second.
Thank you. All those in favor?
Aye.
Opposed? Abstain? Thank you.
Okay, that concludes the topics we plan to present. We are now going to break out into executive session so we can discuss confidential information. I need to read a blurb. Again, we're not going to take any votes or make decisions there. We'll come back to open session to make any final recommendations. So the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to RS 1926602F and RS 4143561 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or to comply with the requirements of RS 4143553. Representatives of the news media and designated staff shall be allowed to attend the executive session, and all other members of the audience are not permitted to attend. Representatives of the news media are specifically directed to not disclose any of the deliberations during the executive session, except to state the general subject of the session as previously announced. No decision may be made in executive session, and at the end of the executive session, we will return to open session. And with that, I'm going to pause. All right, we're just finishing up executive session. We'll get everybody back over on this side, and we can get the committee to take your phones off mute, then I can do a head count and know that we've got our quorum on this side. Okay. We have several classes we looked at that in executive session. I'm going to break these recommendations out into probably 4 different recs. The first one is for the biggest one, the analgesic class update. So after review in executive session, the recommendation is to make, in the muscle relaxants, to make tizanidine 2, 4, and 6 milligram capsules preferred. And for the NSAIDs, make piroxicam capsules, naproxen sodium capsules, indomethacin's ER capsules, and diclofenac extended release 24-hour tablets preferred. To make the ketorolac tablets preferred with the maintenance of the current quantity limits, and to make ibuprofen 300 milligram tablets non-preferred. In the opioids, recommendation is to make morphine sulfate solution, hydrocodone acetaminophen solution, codeine sulfate tablets, butorphanol tartrate spray, hydromorphone suppositories, and opium belladonna suppositories non-preferred, and tramadol extended release 24-hour preferred. For the topical pain medications, to make lidocaine ointment and capsaicin lotion preferred, and to make the lidocaine 4% solution, lidocaine 4% cream, hydrocortisone, pramoxine lotion, ointment and cream, and capsaicin 0.035% cream non-preferred. And for the other oral analgesics, to make acetaminophen drops, tablets, capsules, extended release tablets, rapid tablets, chewables, elixir, liquid, and the 160 milligram per 5 ml oral suspension preferred. Make aspirin, caffeine, acetaminophen, caffeine, and combination aspirin, caffeine tablets preferred. To make suzetrigine non-preferred and to maintain the current quantity limit. So no PA for the first 2 days, 5 tablets of therapy. And to make all other oral pain formulations containing acetaminophen or aspirin non-preferred. Questions about that? Or if not, we'd entertain a motion to accept those PDL changes.
Motion to approve.
There's
Thank you.
Second.
Thank you. All those in favor?
Aye.
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 Any opposed? Abstain? Thank you.
All right, I'm going to combine the next 3. So for the hereditary angioedema DERP report, the recommendation is to make generic icatibant preferred. In the GnRH agonist and antagonist class update, the recommendations are no changes to the PDL. And in the cephalosporin literature scan, the recommendation is to make cefaclor capsules, cefadroxil capsules, and cefpodoxime tablets preferred. Let's limit it to those 3. Any questions, or do we have a motion?
Motion to approve.
Appreciate that.
Is there a second?
Second.
All those in favor?
Aye.
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 Any opposed? Abstain? Thank you.
And finally, for the acne and rosacea class update, the recommendation after reviewing an exec session is to make adapalene cream, both the brand and generic, benzoyl peroxide, the branded Epsilay cream, clindamycin phosphate foam, and tretinoin microspheres gel, both the brand and generics, non-preferred, and the topical generic metronidazole gel and cream, preferred, and all other topical rosacea medications, non-preferred. Questions or a motion?
Motion to approve.
Second.
Thank you. All those in favor?
Aye.
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 Any opposed? Abstain? Thank you.
Fantastic. Well, that concludes the April PMT meeting. Next PMT meeting is going to be scheduled on June 4th. And again, appreciate all your time. And Samara, great job chairing your first meeting. Appreciate it. And with that, yeah, enjoy the spring weather that's springing upon us out here. Hope it is for the rest of you as well. And appreciate all your time. Thanks, everybody.
Thanks all.
Thank you.
Thanks. Care.
Thank you.
Thank you.